Hi, my name is James Joseph. I'm a third-year medical student at the University of Massachusetts Medical School. I'll be presenting our lightning oral presentation about the failure of an audit and feedback intervention to reduce ED/CT utilization. Our authors listed below are faculty at the Department of Emergency Medicine at UMMS. And forward. I have no financial disclosures or conflicts of interest to disclose. So a little bit of background. CT utilization variability results in potential patient safety implications. This includes exposure to ionizing radiation, finding incidental findings based on overuse and overdiagnosis, as well as costs that are associated with all of this. Because of this CT use variability, over and underuse, it's been the focus of multiple national campaigns to attempt to standardize and reduce unnecessary CT utilization. And switching gears a little bit, audit and feedback has been established as an effective strategy to change and modify clinician behavior. And in brief, audit and feedback is the process whereby you collect data, which is the audit part, and you present data back to physicians, which is the feedback, with the goal of changing physicians' behavior in a desired direction. So our goal was to use an audit and feedback intervention to reduce CT ordering by EM physicians. So how did we go about doing this? We conducted a randomized trial to examine the audit and feedback intervention on CT ordering rates. So prior to initiating the intervention, we collected 12 months of baseline CT ordering data per 100 patients treated for every attending physician in 4 different EDs. Physicians were randomized to either a control or an intervention arm, and we did this by dividing the group into quartiles based on CT ordering, and then within each group randomizing physicians to a control or intervention arm. And this helped us ensure that there was an adequate representation of the spectrum of CT ordering across the control and intervention arm. So subjects in both arms actually then received a one-time didactic session that went over CT cancer risk and CT best practices. Those who were randomized to the audit and feedback intervention were then shown a de-identified graphical distribution of the entire group's CT ordering behavior, and they were asked to estimate where in the distribution, which decile of CT ordering that they fell in. They were then shown their actual baseline ordering rate, which completed the feedback portion of our audit and feedback intervention. Next, we collected 6 months of prospective post-intervention CT data for all subjects, and we did this in order to examine the effect of our intervention, if any, on post-intervention ordering while controlling for pre-intervention ordering. So our results, our mean CT ordering rate actually increased in both groups over time, with no significant difference between the groups that was observed. So we failed. Our results, as you can see in the pre section over here on the left compared to our post, showed that both groups, the control being in the orange and the intervention being in the blue, both groups significantly increased their ordering behavior, as you can see by the p-values on the left in the table here. So our audit and feedback intervention failed to reduce CT ordering. Now, within the intervention arm, majority of the subjects overestimated their ordering behavior prior to receiving feedback, and predominantly overestimated self-perception of CT ordering likely contributed to the intervention failing. In other words, our intervention sought to reduce CT utilization, but most physicians in the study thought that they were ordering more CT scans than they actually were, and we hypothesized that the realization that they were ordering less than they actually were may have been a reason that there was no drive or perceived impetus to reduce their CAT scan ordering. So this basically implies to us that the characteristics of the study population are what made this intervention ineffective. So assessing baseline perception compared with the actual behavior before initiating a feedback intervention may be the way to go when using this kind of an approach. And now, another potential cause, such as unmeasured perception of the high stakes of possibly under ordering CTs, may have contributed to the lack of reduction in CT that we observed. So, our results underline the importance of understanding physicians' self perception of performance before implementing an audit and feedback intervention. And such an understanding can help to inform and tailor how data is presented and whether or not to even use a audit and feedback intervention for a particular practice change. And future studies should explore the accuracy of self-perceptions around a broader range of behaviors and desired changes and examine the potential moderating effect on the effectiveness of A&F interventions.
Hello, my name is Vo, and I will be presenting our abstract on the role of cardiac imaging tests in the evaluation of patients admitted for chest pain and compare how different races are impacted. The authors of this paper, including myself, have no disclosures. Chest pain is one of the most common chief complaints that we encounter in the ED. Cardiac imaging tests, or CITs, are procedures that can be performed to risk stratify patients. These include stress tests and cardiac caths. Many patients will have a CIT done prior to an index hospitalization, but the utility of prior CITs as predictors of repeat CIT results has not been well established. We wanted to investigate this association among 3 racial groups. Our study was a single-center, retrospective, observational study at a publicly funded tertiary referral center and chest pain center, receiving about 130,000 patients a year. We retrospectively enrolled patients who were admitted for chest pain deemed high risk for ACS. We further divided our population into 3 racial groups and excluded other races due to small sample size. Our primary outcome was the need for emergent CIT during their index hospitalization. Our secondary outcome were the results of this test if they did receive one. We used multivariate logistic regressions to determine if prior CITs were predictive of these 2 outcomes, adjusting for demographics, including race. We included nearly 13,000 patients, and this table shows the general characteristics of our study populations. When examining ESI levels, we found that Black and Hispanic patients were younger, and their chest pains were considered less emergent than their white counterparts. Hispanic patients had the least number of visits, were predominantly female, tended to arrive via private vehicles, were less likely to have medical insurance coverage, and stayed in the ED for less time. This table displays whether or not an emergent cardiac imaging test was performed during an index hospitalization, and if present, the findings of this index CIT, as well as prior CITs for each racial group. We found that Black and Hispanic patients received less emergent CITs compared to their white counterparts. We also discovered that Black patients proportionately had less abnormal CIT findings. Compared to those who did not receive an emergent index CIT, those who did receive one were more likely to have an abnormal one in the past, as well as a greater time interval from their prior CIT. This table shows the association between prior CIT results on the performance of index CITs across the 3 races. We found that a previous abnormal CIT increases the likelihood to perform a repeat CIT. Time intervals between 2 CITs was significantly shortened if a patient had a prior abnormal CIT compared to a normal CIT. Over 2/3 of patients with previous abnormal CIT received a repeat one within 1 year. This occurred in less than half of the patients with a normal previous CIT. This table assesses risk factors for needing emergent cardiac imaging tests and their potential to predict abnormal results after using multivariate logistic regressions. Black patients comparatively had less CITs performed, but also tended to have less abnormal results. This did not reach statistical significance, though. A patient's chances of receiving an emergent CIT increases with longer time intervals from their prior CIT, and this association was even stronger when their previous CIT was abnormal. A normal past CIT, regardless of time interval, decreases the odds of index CITs being abnormal. The only statistically significant finding that increases the odds of having an abnormal CIT during an index visit was if a patient had a prior abnormal CIT within 1 year. The odds decrease when previous abnormal CTs were done between 1 and 3 years, but again increases at greater than 3 years from index visit. However, this pattern did not reach statistical significance. In conclusion, prolonged time intervals between CITs as well as abnormal past CIT results are two factors predictive for the need of emergent repeat CITs. However, regardless of time interval, a normal prior CIT decreases the odds at predicting an abnormal repeat CIT. This indicates that providers may be overestimating the need for repeat CITs in patients with prior normal CITs. Instead, particular attention should be paid to patients who had an abnormal CIT within 1 year, as these patients may have higher risks of sustaining a new abnormal result and may require intensive management. Black patients were less likely to have an index CIT compared to their white and Hispanic counterparts, but they also had decreased odds at having an abnormal CIT at their index visit. This identifies a potential health disparity that may exist. Thank you for your time and your attention, as well as the opportunity for me to present to you this abstract. I will be open to any questions.
Good evening. My name is Dr. Mary Meinke, and I'm reporting to you from Boston, Massachusetts, as one of the ultrasound fellows at the Beth Israel Deaconess Medical Center. Tonight, I'm going to be discussing with you the accuracy of emergency physician-performed focused echocardiography for identifying regional wall motion abnormalities, a systematic review. I do not have any relevant disclosures to discuss. So, point of care echocardiography has been integrated into our practice as emergency physicians since the early 1970s. We frequently use it to identify pericardial effusions, estimate ejection fraction, identify right heart strain by looking for RV dilation and septal deviation, and identifying regional wall motion abnormalities in relation to areas of ischemia is certainly not new, but it is being increasingly used by emergency physicians to help prognosticate our ACS patients. Now, we have an extensive toolbox to help us with this process of stratifying our ACS patients, including history of present illness, biomarkers, EKGs, and ultrasound is now being considered a fourth element to help us with this process, particularly using the apical four-chamber view, the parasternal short axis view, which is highest yield, and the parasternal long axis view. Now, for a focus assessment, the parasternal short axis view is very helpful, and the overlying cartoon displays the rough regional and vascular distributions that physicians are looking for, specifically looking for areas that do not symmetrically contract or expand, as well as areas that appear thin during systole. These would be indicative of a regional wall motion abnormality. Now, our goal tonight is to discuss the systematic review of how emergency physicians are performing these point of care echocardiograms and how well they are doing at identifying regional wall motion abnormalities when they perform these echocardiograms. We adhere to PRISMA guidelines, completing our systematic review. We define inclusion and exclusion criteria, specifically targeting emergency physicians, both attendings and emergency physicians in training. There need to be a specific mention of regional wall motion abnormalities. There need to be a comparison to a reference standard, whether that be angiography, a comprehensive echocardiogram, or cardiology review. And then also need to be mentions of sensitivity and specificity, or have data that we could then calculate the sensitivity and specificity. Our search strategy included searching published databases such as PubMed, Embase, Cochrane database, and the Web of Science database using mesh terms. We had 2 independent reviewers that screened abstracts, as well as a third reviewer that resolved conflicts. We then calculated the pooled estimates of sensitivity and specificity, and we did a bias assessment once our studies had been selected. We screened a total of 3,671 studies. We had 8 studies included in our final meta-analysis. We did have an additional 3 conference abstracts that fit our inclusion criteria, and we completed an analysis including those abstracts as well as not including those abstracts. Number of patients in the study selected ranged from 43 to 1,312 with a median of 95. These are our final studies that were included. As you can see, there are both domestic and international studies included. The type of ACS ranged from both NSTEMI and STEMI patients, and the majority of our studies were prospective observational, with one prospective cross-sectional study and one retrospective observational study. Our final analysis revealed a pooled sensitivity for emergency physicians to detect ACS of 84% and a pooled specificity of 84% as well. There was no evidence of publication bias, both by visual inspection and by slope coefficient. Heterogeneity was also assessed with a measured I-squared of 0%, indicating no substantial heterogeneity. Cochrane's Q was also assessed, and there was no substantial differences between studies. Analysis with conference abstracts revealed a similar pooled sensitivity and specificity of 82 and 84% respectively. However, there was substantial heterogeneity and there were substantial differences between studies when the Cochrane's Q was assessed. Our bias assessment did reveal some bias pitfalls, including evidence of convenience sampling, as well as multiple reference standards used, which could introduce bias. And there was some variability among training of the emergency physicians. But as you can see, most of these pitfalls of biases were within the conference abstracts that were ultimately excluded from analysis. In conclusion, it looks like emergency physicians are quite adept at identifying regional wall motion abnormalities with a high sensitivity and high specificity. And point-of-care ultrasound should be more frequently integrated when stratifying our ACS patients, and there may be an educational opportunity to help better standardize the interpretation of regional wall motion abnormalities among emergency physicians. Thank you so much from our Division of Ultrasound at Beth Israel Deaconess Medical Center, and we're wishing you a wonderful rest of your evening.
Hello, my name is Evan Shapiro, and I am presenting our abstract about recognizing patterns in billing denials for emergency department point-of-care ultrasounds. I am presenting on behalf of my co-authors, Dr. Brett Nelson and Dr. Fred Milgram. We have no financial disclosures or conflicts of interest. Point-of-care ultrasound has become a fundamental part of the training of an emergency medicine provider and serves as an important tool for diagnosing, monitoring, and treating a wide variety of conditions. In 2012, the ACGME designated ultrasound as one of the 23 milestone competencies for emergency medicine residency graduates. Despite the training and expertise required to perform and interpret a diagnostic point-of-care ultrasound exam, reimbursements remain low. Only 1.3% of emergency medicine workforce clinicians were being reimbursed for diagnostic point-of-care ultrasound in 2016. Point-of-care ultrasound reimbursements impact an emergency department's ability to fund continued education and to maintain a quality ultrasound division. Through the lens of a single emergency medicine system, we aim to identify generalizable trends in point-of-care ultrasound billing denials in order to improve future revenue capture. We examined 7,508 billed ultrasound studies across 6 emergency departments in a single calendar year. All exams were either performed or supervised by an attending physician credentialed in the given exam type. Reimbursement denials and percent reimbursements were analyzed according to exam type, payer, and denial reason. 18 different exam types included in the 2020 ACEP Emergency Ultrasound Coding Guide were analyzed. Denial reasons and payers representing greater than 90% of studies billed were included. Of the 7,508 exams included in the analysis, 3,509, or 47%, were denied reimbursement. 75 different denial reasons were identified, and this graph includes the top 18 denial reasons, which accounted for greater than 90% of denials. As you can see on the left side of the graph, 1,028 out of the 3,509 exams denied reimbursement did not have a reason provided for the denial. The most common reason that was provided was included in the payment for other services, commonly referred to as bundling the payment. This was followed by the reason services not authorized by primary care provider, all of which were denied by a single insurer. The following chart demonstrates the wide range of percent reimbursement based on exam type. The exam types with the highest percent of reimbursement were pelvic non-pregnant transvaginal ultrasounds at a reimbursement rate of 89%, followed by central line placement at a rate of 80% and cardiac ultrasound at a rate of 68%. The exam types with the lowest percent of reimbursement were breast ultrasound at 14% and ocular ultrasound at 21%. This wide range of reimbursement was again observed in the analysis of denials based on insurer. The payers included in this graph represent greater than 90% of all billed studies. The self-pay group had a reimbursement rate of 0%. Medicare had one of the highest reimbursement rates at 88%, and Medicaid fell somewhere in the middle with a reimbursement rate of 62%. 46.7% of billed ultrasound studies were denied reimbursement. This denial rate exists while following ACEP guidelines and previously described ultrasound billing frameworks comprised of image storage along with the documentation of exam indication, findings, and interpretation by credentialed providers. Given that nearly 1/3 of billed ultrasound studies denied reimbursement did not have a denial reason listed by the payer, transparency is a major barrier when trying to optimize revenue capture. The most common denial reason of being included in payment for other services goes against ACEP's support of point-of-care ultrasound being a separately billable procedure. Other reasons for denials, such as services not authorized by primary care provider, would seem to be inconsistent with an emergency care visit. We can also conclude that a wide range of reimbursement rates exist both by insurer as well as exam type, and further investigation is needed to determine the reason for this wide range. Hopefully, as other institutions investigate their own denial patterns, we can collectively improve revenue capture for point-of-care ultrasound in the future. Thank you for listening.
Good afternoon. My name is Dr. Elliot Chin, and I'm a research fellow at Hennepin County Medical Center in Minneapolis, Minnesota. Today, I will be presenting the Association of Reduced Left Ventricular Function on cardiac ultrasound and mortality in sepsis patients. Sepsis has a significant impact on our daily practice as emergency physicians. Every year, we treat 1.7 million cases of sepsis in the United States. On average, there are 270 deaths attributed to sepsis annually. The annual cost for this disease is well over $20 billion. Septic cardiomyopathy is a sepsis-associated acute syndrome of cardiac dysfunction unrelated to ischemia. There is no universal way to diagnose it, and most definitions use echocardiography. Most studies on septic cardiomyopathy take place in the ICU after patients have been resuscitated. Studies taking place in the ED prior to volume resuscitation are lacking. Thus, the prevalence and prognosis may differ from the ICU. We therefore set out to answer 3 questions to address this knowledge gap. First, to establish the prevalence of reduced LV function in the ED by point-of-care ultrasound in patients meeting sepsis criteria. Second, to determine the difference in prevalence of abnormal findings as documented by ultrasound trained versus non-ultrasound trained faculty. And finally, to determine the association of decreased LV function with mortality. To be included in this study, you need to be 18 years or older, have suspected sepsis as given evidence by receiving IV antibiotics in the ED while having either 2 or more SIRS criteria or an estimated SOFA score of 2 or greater. Exclusion criteria was the absence of a cardiac ultrasound. At our institution, the majority of ultrasounds are recorded, saved in PACS, and an attending physician approves the resident's interpretation or adds their own. Taking a random sample of 200 cardiac ultrasounds from our study population, we identified if there were any phrases identifying reduced left ventricular function. We use those terms to write a code which would identify any key phrases suggestive of reduced left ventricular function and then tested on another sample of 200 cases. We calibrated the code on the second sample of 200 patients, then calculated inter-rater reliability by using the code and 2 ultrasound trained faculty members. We queried our EMR, EPIC, for any case that met inclusion criteria between when we started using EPIC in 2007 until November 1st, 2019. 22,815 patients met inclusion criteria, and out of those, 2,761 were excluded due to the absence of a cardiac ultrasound in the EMR. This left us with 2,051 patients. Prior to proceeding with the study, we calculated our inter-rater reliability using FLICE kappa, which was 0.91, or excellent inter-rater reliability. Here are the results. Demographics, the average age, or the median age, was 61. Predominantly male, fairly diverse. Pretty much everybody was in cohort 1, less were in cohort 2. A fair amount were on vasopressors or intubated, and the most amount of patients went to the ICU. Finally, 8.9% of our population died. To answer our first question, what is the prevalence of reduced left ventricular function in patients meeting sepsis criteria? We found that between the 2 cohorts, 14% of patients had reduced left ventricular function. Here is a breakdown comparing cohort 1 and 2, identifying which proportion of each had subjects with decreased left ventricular function. In cohort 1, this was 14.3%, and in cohort 2, this was 18.8%. To answer our second question, whether ultrasound training makes a difference in the proportion of subjects identified with decreased left ventricular ejection fraction, we did a chi-square analysis and found that there was no difference between the rates for those with and without advanced ultrasound training. To answer our final question, we performed logistic regression using the presence of decreased left ventricular function to predict inpatient death. While the unadjusted model could predict mortality, after adjusting for age, sex, and race, the presence of decreased left ventricular function was not a valuable predictor of increased mortality in cohort 1. In cohort 2, neither the unadjusted nor adjusted model were valuable predictors of mortality. There are several limitations to the study. It was retrospective, over 20,000 patients were excluded, it was limited to systolic dysfunction, and we did not calculate a total SOFA score to control for severity of illness. In conclusion, 14% of patients meeting sepsis criteria had decreased left ventricular ejection fraction. Advanced ultrasound training did not affect the proportion of cases identified, and decreased left ventricular function was not an independent predictor of mortality in this study. Thank you for your time.
Hello everyone, I am Liang Liu. I am ultrasound faculty within the Department of Emergency Medicine at Emory University. Today I will be presenting a distance learning approach to POCUS training curriculum, an innovative ultrasound education response to the COVID-19 pandemic. I would like to acknowledge my co-authors listed here. I have no financial disclosures or conflict of interest. The COVID-19 pandemic disrupted traditional models of medical education. Social distancing mandates and clinical staffing concerns led to a rapid transition from bedside education to either virtual platforms or, in some cases, outright cancellation of training experiences. Point-of-care ultrasound traditionally requires a hands-on curriculum. Early in the pandemic, POCUS educators were tasked to rapidly redesign the traditional curriculum for the virtual arena. This project attempted to address this challenge. Core POCUS competencies include medical knowledge, psychomotor skills for image acquisition, image interpretation, and integration into clinical decisions. To address these competencies, traditional POCUS education consisted of a combination of these offerings: didactic sessions, asynchronous learning opportunities, bedside instruction, and remote image review. The goal of our intervention is to develop a curriculum that addresses these same 4 competencies but through a virtual platform. While remote teaching of didactic and hands-on ultrasound skills have been previously described, This intervention is unique in its scope as there is no previously described comprehensive, multi-centered, remote POCUS training curriculum that addresses both the cognitive and hands-on components of POCUS education. I'd like to describe the development of the curriculum, the perceptions of its participants, and lessons learned during implementation that may be applicable for post-pandemic education. In March 2020, we sent an invitation via targeted emails and the ACEP listserv proposing collaboration in response to the challenges posed by COVID-19. 15 institutions in total responded to the call, and ADAPT, a distance learning approach to POCUS training, was born. This map showcases the geographic distribution of these institutions. Educators developed lesson plans and learning objectives for each topic. A shared document of the curriculum was made available to all participants and included daily logistics, pre-work, and learning objectives. The curriculum covered core POCUS topics and included pre-work and virtual teaching by a rotating group of 30 faculty and fellows via Zoom. Gamification and teleguidance strategies in which learners had the opportunity for remote proctor scanning with handheld devices were incorporated into these sessions. Learners could also perform independent ultrasounds, which were stored in a collaborative cloud that enabled image review across institutions. ADAPT provided 3 iterations of the curriculum over April, May, and June 2020. It targeted first-year EM residents on their 1 to 4 week POCUS rotations. Similar to traditional POCUS rotations, ADAPT included a blended audience of fellows, off-service residents, and medical students. At its conclusion, faculty and learners completed anonymous surveys evaluating the curriculum. This prospective educational interventional study was reviewed and granted exempt status by the Stanford Institutional Review Board. Here are the survey results. 29 of the 70 participating learners completed the survey. Learners participated in a meeting of 6.5 days with a wide range of 1 to 20 days. This is compared to once weekly didactic instruction in pre-pandemic times. The majority of learners reported extra clinical responsibilities that interfered with attendance. Of the programs with access to handheld ultrasound devices, 29 learners cumulatively performed and saved 998 exams to the Butterfly Cloud. The majority of learners felt somewhat confident or very confident in their ability to acquire and interpret ultrasound images after ADAPT. 15 learners reported limited access to clinical scanning during their ultrasound rotation. There was no significant difference in learner confidence regarding image acquisition or interpretation among those who did or did not have access to clinical scanning. 22 of the 30 participating educators completed the survey. Each faculty participated in a meeting of 3 days. Educators reported a significant decrease in preparatory time from 6.2 to 3.1 hours per week due to the intervention. The majority of educators felt that the program was somewhat effective or very effective at contributing to learners' ability to acquire and interpret images. All educators and 96.6% of learners were satisfied or very satisfied with ADAPT as a whole, and 81.8% of educators were very likely to recommend continuing use of the program. Most learners and educators surveyed also responded to open-ended questions. Thematic analysis of these questions yielded notable recurring themes. Themes related to the strength of ADAPT included access to a diverse group, depth and breadth of didactic offerings, access to handheld devices at home, and sharing the workload. Themes related to areas of improvement include prioritizing learner engagement and optimizing schedule coordination. Our work demonstrates that virtual curricula can provide a satisfactory and effective learning experience. The collaboration satisfied educational needs while increasing national engagement and reduced workload on individual faculty. The success of this endeavor provides a usable framework for further collaboration during pandemic events and may be generalizable to other educational objectives. Here are my references. I would like to acknowledge these institutions for their contribution to ADAPT. Thank you, and feel free to reach out with any correspondence to my.
Good evening, everyone. My name is Tyson Jackson. I am a PGY2 EM resident at Kendall Regional Medical Center located in beautiful Miami, Florida. I am excited to present the study entitled A Retrospective Data Study Showing Incidence of Fracture Types in the Emergency Department. The initial inspiration for this project stems from my passion for sports medicine. During my time as a medical student and as a resident, I have seen my fair share of fractures. I'm sure those of you listening are no strangers to fracture management either. I wanted to know how much of a burden fractures place on the emergency department. I hope that this information can be used to make the emergency department more efficient and possibly on a larger public level with preventative strategies, especially for the elderly. Enough of me talking. Let's get into it. I'd like to first acknowledge and thank Dr. Tony Zidek, who helped me with this project. He helped crunch some numbers and was very insightful and informative during the analysis. In addition to Dr. Zidek, Dr. Brandon Stein helped me brainstorm how best to present the data and make it interesting. Kelvin Matthew is a medical student from Nova Southeastern University and did a lot of the background research that we will discuss later on. As stated on the slide, we have no financial conflicts of interest to disclose. The primary objective of this study was to determine the most common fractures in the emergency department. We accomplished this by leveraging the large amount of data from HCA with its vast network of hospitals across the nation. The secondary objective was to stratify the information by fracture type or location, age, gender, race or ethnicity, geographical location, or admission period. Acquiring the data and then stratifying it allowed us to focus on specific age groups and populations who are at highest risk of fractures. The hope is that this information can be used by medical directors and public health officials to properly address fracture management in the ED as well as preventative measures in the community. As previously stated, one of my passions is in sports medicine, including the management of fractures. This study was born from a simple search of literature about the most common fractures encountered in the ED. While searching, I found that there lacked large volume studies in the US about overall fracture rates. Most of the studies that I found were international studies that focused on specific fracture locations or specific age groups. I could not find a study that investigated general incidence of fracture rates that combined pediatric, adolescent, as well as elderly populations. Knowing I had access to HCA's database, I got to work. At this point, I'd like each of you to guess what you think are the top 3 most common fractures, at least according to this study, in the emergency department. We will answer this question in a few slides. IRB exemption was obtained, and a query of the HCA database was performed. Initially, we had a goal of acquiring at least 100,000 patients, but ended up with more than double that amount. Additional stratifying information was also requested. Once the data was obtained, we made a few exclusions. We only wanted to look at the initial visit for a fracture, so we excluded all subsequent encounters or sequelae associated with the fracture. We also excluded any diagnosis that did not specify a fracture location. Now for what you've all been waiting for. Here are the results that we found after applying the exclusion criteria. We examined over 275,000 patient encounters, and when everything was said and done, we were left with over 300,000 fractures across 162 hospitals in the United States. Coming in first place was the femur, with just over 22,000 fractures, followed closely by radius and rib fractures. Coming in fourth and fifth respectively were fractures of the phalanx and metacarpal bones. I believe there was a lot of insightful information that was obtained from this retrospective analysis. The volume of patients and fractures compiled will allow for further analysis and stratification that could prove to be beneficial for furthering the care and management of fractures in a specific location or for a specific population. Unfortunately, we don't have time to go over the stratification results today. Unlike previously studies, this study was able to leverage the sheer volume of patients and hospital data from the HCA database to produce a comprehensive list of fracture types that can be further stratified into the categories we previously listed. How did you do? How did your guess for the top 3 fracture locations compare with that of this study? Did you see a higher incidence of a different fracture location at your individual shop? How would you use this data to help ensure that your ED is prepared to manage and treat the most frequently encountered fractures? As a resident, I know I can focus on increasing my knowledge of the most common fractures and how to best manage them efficiently in the ED. I hope to reduce the morbidity and mortality associated with some of these fractures, especially in the elderly. I hope that this can also make the workflow in the ED more efficient and provide better outcomes for patients. I appreciate you taking the time to listen to this presentation and for the opportunity to present at the SAEM conference. Thank you.